Dr. Ian Wright here.
And before I was recognized as an orthopedic and sports clinical specialist by the American Board of Physical Therapy Specialties, I was, and still am, a strength and conditioning coach first and foremost. And I am not talking about being that guy with the letters of CSCS or SCC after my name without having the real world experience to back it up. As prior to becoming a physical therapist, I was a sports performance coach practicing in the real world with real athletes, gaining real time experience within the profession of strength and conditioning at the intern, assistant, and head coach levels, respectively. And I think it's important to highlight this fact as really my experiences both as a strength and conditioning coach and later on as a physical therapist laid the foundation for me building a bridge program tailor-made to returning athletes back to sport, and then performance, who were status post ACL reconstruction for one of the top pediatric orthopedic hospitals in the United States. And as difficult as this bridge program was for me to create from scratch, in a lot of ways, it laid the foundations for the development of the periodized ACL course that I wish to talk about to everyone watching this video. So, I think most coaches and clinicians who work with athletes know that the integration and application of theory and best available evidence to clinical practice in sports performance is difficult, especially when we are missing pieces of the puzzle as healthcare providers and or sports medicine professionals. When I first started off in strength and conditioning, I interned for free. Or do I dare say I paid for the privilege to learn from what I perceived to be some of the most reputable names in the industry. Names like Anthony Donskov of Donskov Strength and Conditioning. This took me at the time from the typical egomaniac meathead of a student who thought he knew it all to a humbler and more grounded professional that realized he had a lot to learn from within the industry and the names that dominated it, guys like Mike Boyle. And while I became less mediocre in retrospect from intern opportunities like that I experienced from Donskov Strength and Conditioning, and then later on during the refinement of my skills from other part-time and full-time assistant coaching positions that I held in the private sector of my strength and conditioning career. This process of refinement for developing my coaching style and skills culminated in what I thought at the time to be the peak of my coaching career when I landed a position within the NHL for the Columbus Blue Jackets. And I think it's important to point out that this experience of working in high performance afforded me the opportunity and set me really down the path for gaining the necessary hands-on experience of coaching and directing team workouts for both injured and healthy scratch players on a daily basis, for designing in-season and off-season athletic development programs in collaboration with the head coach, and for developing and implementing training protocols during this time for the rehabilitation and reconditioning of injured athletes, all while working closely with team physicians, physical therapists, and athletic trainers. Now, while I am grateful for the experiences that I just laid out, as I gained a lot of hands-on experience seeing the high-performance model of training in action due to me witnessing the various sports medicine disciplines working and collaborating together in the professional ranks, if I am being totally honest with everyone as I self-reflect here, I still was an incomplete coach at best. Sure, I could command a weight room and make it flow, or I could write long-term athletic development programs while communicating effectively with others, or I could perform data collection while screening athletes, and really so many other of the essential and critical day-to-day functions of a strength and conditioning coach. There was still a lot I couldn't do, however. For instance, I was still very ignorant of teaching skill work and field work within a lot of the major sports, as I had established no philosophy or system from which to do so, as I relied exclusively on skill coaches for this task accomplishment. I also had almost a non existent knowledge of conditioning means and methods, let alone a teaching blueprint for me to improve athletes' change of direction and agility mechanics. And obviously, I couldn't diagnose an athlete while crafting a plan of care for their rehabilitative needs for the life of me. I was totally dependent on sports medicine professionals like athletic trainers and physical therapists to tell me what I could and could not do with an athlete. Essentially, I gathered a tool set like so many other coaches within the profession of having essentially a PhD in weight room movements while simultaneously having a GED in all other aspects of human performance. And I did this all while believing the lie that if I got athletes bigger, stronger, and to a degree faster, that I did my job. I effectively ignored the most basic of principles, the dynamic correspondence principle, with regards to programming strength and conditioning work for transferability to the athlete's sport, let alone the refinement of it. I felt that if I could justify X amount of increase in a clean, or squat, or bench press, or Y amount improvements in sprint times or jump heights, that I did my job. Essentially, I felt that if I measured all the things I could manage within the prototypical weight room environment, I justified my existence and place for remaining within the sporting organization, where I should have instead focused on how I could have better served my athletes in their ability to become the best at their position from within their sport for the longest time possible. I knew I had to do better. I knew I was unfit to continue in the position I was in, so I made the rational decision most people would probably make in my position. I went back to school. So I think it's no secret that on the application side of things for colleges and universities here in the United States, from at least a kinesiology or rehabilitative perspective, things are lacking, and to a degree, in a word, dysfunctional, especially in sports medicine. You learn cool things like conducting VO2 max tests, lactate threshold testing, body composition testing using various means and methods like calipers, pod, and so on in your undergraduate studies for these disciplines. Then, in grad school, at least in physical therapy curriculums, you get a generalistic education in performing evaluations and assessments for diagnostic and prognostic purposes of the common orthopedic, neurologic, and acute care setting conditions, with some additional surface level treatment options sprinkled in the mix there as well. But really, in both instances, schools assume you gain the real world experience in the refinement and application of the skills you learned during the didactic portion of your studies during your internships or clinical rotations. And of course, this assumes you had a good mentor, coach, or clinical instructor who learned these skills so that they could teach them to you in the first place. And I found out this disappointing fact the hard way, as after I graduated from PT school, I still had none of the answers I sought when enrolling in the first place. In higher education's defense, it was a big ask, and why I thought I would find my answers to optimizing human movement for success in sport from within a single profession was narrow sighted thinking to begin with. However, good things did come from my studies in physical therapy, namely my gaining of a greater appreciation of the performance injury conflict all athletes invariably sit on when competing in their respective sports. It allowed me to see that different professions and disciplines within the sports medicine field all sit on a continuum from one another, and that all these professions face or are trying to solve overlapping problems that no one individual profession can solve. Finally, my graduate studies also allowed me to really gain an appreciation of taking an athlete who in a lot of ways is at their worst functionally after they sustain an injury that requires major orthopedic intervention and subsequent surgery through that rehab performance continuum. It allowed me through a whole lot of trial and error and really failure to gain an appreciation and better understanding of the sporting qualities I needed to develop and the systems I could implement for this task accomplishment within a wide range of athletes in order to best physically prepare them to handle the demands of their sport. This realization eventually led me down an unconventional path where ultimately I got to draw upon my experiences from both my strength and conditioning background, where I functioned as a sports performance or physical preparation coach, and from my background as a sports physical therapist, in order to build separate bridge programs within both the private sector and at one of the highest ranked orthopedic pediatric hospitals in the United States, Scottish Rite for Children. So, as a new grad student just out of PT school, I sought what I knew, and I began my career by looking for opportunities that allowed me to work with athletes. I eventually ended up in the Baltimore area where I worked for a private practice owner who rented out space from within various gym and fitness centers, as that allowed him to cultivate access pretty immediately to a varied sports population. This in turn allowed me to work with athletes not only from the recognizable sports of football, baseball, basketball, and soccer, but also some of the more niche sports as well, such as lacrosse, MMA, swimming, and so on. So, really, yet again, I jumped back into the sports performance world, this time not as a coach, but as a clinician. And I think at the time, being a new grad who was just freshly minted with his Doctor of Physical Therapy license, this was the best thing that could have happened to me because I got to approach human performance from a completely different viewpoint and with clinical reasoning and critical thinking skills that were much further developed when compared to my time as just a coach. Additionally, here I got to meet strength and conditioning coaches, physical preparation coaches, and skill coaches from the Baltimore area who had a lifetime of knowledge that they could impart to me, with none more influential than the owner of Sweat Performance, Kyle Jacoby. While Kyle did not particularly care for my physical therapy employer, to whom he rented out space for rehabilitation purposes from within his sports performance facility, for some reason we seemed to click. Maybe it was because of my background as a strength and conditioning coach, or maybe because it was the way I approached rehab and sports performance. But whatever the reason, we eventually cultivated a relationship which was mutually beneficial to the both of us. And really, this relationship led to the development of my first bridge program that I oversaw within the private sector. Personally, I think Kyle and I clicked because he knew that when I referred him a patient athlete after I completed the rehabilitative plan of care, that A, the patient athlete was firmly ready to be reintroduced into a group physical preparation setting with other like minded athletes who were attempting at a minimum of returning back to sport and ideally reach the next level from a performance standpoint. That B, I would articulate to him or his staff in detail any precautions or training modifications that they needed to make when working with injured or post surgical patients from a timeline perspective. And that C, and this is really the most important factor here, that I had the best interest of the athlete in mind. This was actionably demonstrated by me not keeping an athlete in rehab longer than I had to. I was still a generalist at this time as both a coach and clinician, so I immediately made a referral to coaches who I thought were specialists and frankly better suited than I was at the time in helping the athlete achieve their performance and long-term athletic development goals for their sport. And truth be told, these facts I just detailed were frankly not even remotely feasible between the coaches at Sweat Performance and at the private physical therapy practice I worked for before I arrived. The norm at the practice I worked for was definitely to be territorial and to keep athletes as long as possible from a plan of care perspective, all while being able to justify to insurance companies the need for continued PT through a short sighted narrative of putting practice needs before patient needs. And I can confidently say that the culture changed quickly and lucratively for everyone involved once I began implementing what I knew best from my previous experiences in high performance, which was a team approach to patient care and athletic development. Ultimately, over time, my relationship with Kyle and the coaches at Sweat Performance grew into a mutually beneficial one for everyone involved as learning opportunities like in services were provided to one another, along with company outings and so on. But it eventually developed to the point of when athletes got injured while training or competing in their respective sports during in season activities, the Sweat Performance coaches would make an introduction to me day of injury because of the direct access privileges allowed for physical therapists in Maryland. And I, in turn, got those individuals back into the hands of their coaches as safely and quickly as possible so that they could continue training. Essentially, I became their preferred provider, and this relationship eventually blossomed into one that occurred for all levels of sport, as the needs of athletes were addressed in this fashion, using the tactics I just described, anywhere from the high school, college, and professional ranks. Toward the end of my time in Baltimore, the trust between the Sweat Performance staff and I eventually developed to the point of where they too were assisting me in the rehabilitative needs of athletes who were performing prehab prior to them undergoing major orthopedic surgery, which was in addition to them also assisting me in the rehabilitation and subsequent return to sport and performance needs of athletes who were status post ACL reconstruction anywhere from the 3 month post op mark and after. So, just like they expanded my skill set and understanding of speed development both linearly and curvilinearly, let alone from a change of direction and agility perspective, I increased their knowledge and skill sets as strength and conditioning and skill coaches from a rehabilitative and responsibility of care standpoint, as they now had the opportunities to work with injured athletes. Essentially, their scopes of practice were enhanced to that which were typically reserved for professionals like assistants and technicians in physical therapy. And of course, the relationship between the coaches of Sweat Performance and I also opened up plenty of personal training opportunities for the staff to take advantage of as well. But in the end, with me following my now wife to Texas in order for her to finish her surgical residency, I decided to leave Charm City. And this was despite Kyle throwing in the generous offer of financing my own private practice with him and his staff, and at no risk to me, all the way to the point of where I didn't need to make a penny for a full year. Upon arriving to Texas in 2019, I accepted a pediatric sports physical therapist position at the Frisco branch of Scottish Rite Hospital. Now, coming from an environment in Baltimore where I was predominantly working with returning higher caliber athletes back to sport and then performance from the high school, college, and professional ranks while in a direct access setting, there was an adjustment period for me that was needed when setting foot in this establishment. For instance, diagnostics from a physical therapy perspective was non existent here, as all admitted individuals came with a complete diagnostic workup in the form of advanced imaging and already having seen one of two individuals, either a sports medicine physician or a sports medicine physician assistant. Now, while convenient for me because I got the opportunity to really experiment with my interventioning and treatment means and methods on athletes of all different sports, as that was all I was allowed to see was athletes within this division of Scottish Rite, I also felt uneasy about this aspect of the job. After all, diagnostics and prognostics is half the job of a physical therapist, and these skills I effectively shelved during my time here because they weren't needed. Additionally, here I had to adjust to the fact that the sporting division of this hospital wasn't what I was accustomed to. Athletes here were treated, quite frankly, with low level therapeutic exercises and activities that were not graded progressively, as demonstrated by the weight room and turf fields sitting empty throughout most of the clinic's working hours, as the go to interventions therapists and technicians performed with patients here largely consisted of those that were either body weight in nature or those that utilized TheraBand. The demands of these rehabilitative interventions also in no way, shape, or form prepared athletes to meet the demands of returning back to their sport at a performance level equal to that or greater than that from where they were at pre injury. And upon this rather quick realization of mine within the first week of my employment at Scottish Rite Hospital, I thought to myself, there is opportunity here. After all, at Scottish Rite Hospital, I had access to collaborative opportunities that easily enabled me to engage with a wide variety of other sports medicine services and personnel. Anything from a fracture clinic to a prosthetics and orthotics division to a movement science laboratory, and so on. I also had the ability here to being able to work with and collaborate with ancillary staff members comprising that of a typical hospital system. So things like orthopedic surgeons, PAs, NPs, nurses, PTs, OTs, ATs, and so on. Essentially, I realized I was not in too different of an environment from that of where I was at pre PT school, as most of the pieces for a high performance model of sport at Scottish Rite Hospital were already in place. They just needed someone to fill in the gaps and make them come together. So, if we fast forward a year, the culture at Scottish Rite Hospital within the sports division at the Frisco campus changed dramatically for the better as I demonstrated a number of my philosophies and systems to my peers that utilized an assortment of rehabilitative means and methods from a therapeutic exercise, therapeutic activity, and from a strength and conditioning viewpoint. I introduced my philosophies for different athletes' rehabilitative needs and for their overall long term athletic development for their respective sports from a linear, curvilinear, change of direction, agility, and neurocognitive standpoint as well during this time. Patients who were status post ACL reconstruction during this time started as a whole to pass the return to sport testing more consistently, and by all measures, the quality of rehab provided by the sports division at Scottish Rite improved. It improved to such a degree that a bridge program initiative, which was floated years before I arrived by the staff at Scottish Rite Hospital, eventually even turned into a reality. Now, at this point, I was not running the bridge program at Scottish Rite Hospital as I had no interest in launching this new initiative due to me knowing the amount of work it would take to implement this program correctly, especially being that I just created a program of similar caliber in the private sector just a few years earlier. I didn't feel the compensation offered to me initially by Scottish Rite Hospital matched the workload, so I declined the offer and deferred it to one of my colleagues who was a former assistant strength and conditioning coach collegiately. After all, it was his idea long before I arrived to the scene to create a bridge program from within the Scottish Rite Hospital system. And for whatever reason, he too decided to not put his words from the last few years into action as he deferred the program's creation to outside resourcing by the hospital in the end as well. This led the hospital to hiring a new grad with his master's in kinesiology or exercise science for the first bridge program coordinator position in Scottish Rite Hospital's history. On paper, he had a lot of experience with coaching different college teams from within the University of North Texas system, and he was a qualified candidate overall, as this individual was a lifelong athlete himself that was also practicing what his resume preached as he was striving to become a future CrossFit Games athlete too. So, as a PT, it became my job during this time, along with my PT co workers as well, to fill in the gaps of clinical knowledge for our new bridge program coordinator so that he could design, organize, facilitate, implement, and ultimately engage through coaching performance training for classes comprised of a varying number of pediatric and adolescent patient populations that were transitioning back to return to play and or sport as a complement to and in conjunction with traditional sports physical therapy. Essentially, this individual had to design a program like the coaches at Sweat Performance did, and at the same time, make it successful. Now, due to our bridge program coordinator's comfort level, most post op patient athletes weren't admitted into the program until at least 9 months from their initial date of surgery. And this was obviously 100% understandable, as Scottish Rite Hospital wanted all patient athletes to remain safe during their stay while they were using the hospital's facilities and resources. Additionally, everyone at the time thought the program would fill with ease, regardless of any accommodations that needed to be made due to the volume of patients seen by the sports physical therapy staff at Scottish Rite Hospital, as hundreds of post-op patients alone were seen yearly just from a lower extremity perspective by the staff, as things like post-op ACLs, MPFLs, OCDs, hip scopes, and so on were all too familiar to the staff even at the 9-month mark. Really, any accommodation that needed to be made in order to meet the bridge program coordinator's wants, the physical therapy staff and the administrators at Scottish Rite Hospital were happy to make, as everyone was just excited to alleviate the access to care bottlenecks presented to the hospital, as clinically, the surgical volume offered to the therapist by the surgeons was overwhelming, and this resulted in a lot of referrals out to the network. Obviously, this need to refer out also resulted in the hospital losing money by them not being able to capture all surgical patients clinically. So, between potentially alleviating the patient care bottleneck clinically that was created from massive operating volumes at Scottish Rite Hospital and the potential extra revenue stream offered through performance training itself with the creation of this new bridge program, everyone was incentivized, to say the least, for the program to succeed. Unfortunately, while everyone expected slow growth with the launch of any new initiative, after 6 months, the program was limping along, to say the least. With no more than 9 participants in the program for any given month, or no more than 4 individuals in any class, the program's existence looked to be in question. Then in March 2020, a global pandemic hit, and a few short months after that, in the summer of 2020, the program officially closed. So, what went wrong? A re-examination needed to occur of the facts. The first question became, did everyone at Scottish Rite Hospital agree for the need of a program to be developed for athletes who completed their physical therapy sessions, but who still needed focused training in helping them return safely back to their sport? And the answer was yes. Everyone at Scottish Rite Hospital knew and agreed for the need of a program to be developed to bridge the gap, so to speak, between discharge from therapy and safe return to sport. The second question became, did everyone at Scottish Rite Hospital also agree for the need of a program to be developed for healthy athletes who needed specialized training for injury reduction or prevention reasons that also sought to optimize their sport performance? And the answer was yes. Everyone at Scottish Rite Hospital knew and agreed for the need of a program to be developed to improve athletes' movement quality and efficiency through their training and development of the following areas: their hypertrophy, strength, power, ability to handle plyometrics, speed, and pivoting or change of direction ability, and so on. So, the third question became then why did this program fail if the answer to the previous two questions were yeses? The answer was obvious to me. It's a big ask for any one professional to successfully implement a bridge program, accomplishing all of the goals that I just laid out. In hindsight, to me at least, no one individual can usually successfully implement a program as diverse as a bridge program because of the team model that is required as demonstrated by the high performance model of sports. Simply put, a single degree with experiences limited to the scopes of practice of that degree only in any of the health professions cannot prepare any one individual for success in the creation of such a large initiative as a bridge program that aims to commingle and house both healthy and injured athletes while additionally attempting to return them back to performance or ideally improve upon it while simultaneously reducing injury reoccurrence and incidence rate in the first place. It's a huge ask, and as I previously detailed, it was the reason I went back to school in the first place, as I figured this out during my time as a strength and conditioning coach. It's the reason I sought out the experiences I did in my professional career to this point as well, as all these experiences I gathered led me next to getting my opportunity to become the next bridge program coordinator at Scottish Rite Hospital. So, out of desperation due to the pressure she was under by the administrators at Scottish Rite Hospital to build this bridge program successfully, my boss reapproached me with the offer for the bridge program coordinator position as she knew my skills as both a clinician and coach. After all, she witnessed my clinical skills every day while I was at work for Scottish Rite Hospital as a physical therapist, and she also knew I just brokered a partnership with Texas Scottish Rite being the preferred medical provider for one of the wealthiest private schools in the area, Green Hill School. And she knew I did this not based on my skills as a physical therapist, but rather based off of my skills and reputation as a strength and conditioning coach, as I also worked part time at Green Hill School during this period of my life as a sports performance coach, where I was responsible for the off season, preseason, and in season design, implementation, training, and coaching of various sports teams, including the American football, women's soccer, women's tennis, men's lacrosse, JV baseball, and the track and field team. But despite her desperation, I declined yet again because of what they offered me as compensation. After further rounds of negotiations that took months, Scottish Rite Hospital eventually offered me an acceptable salary on my terms, so I accepted, and thus the bridge program was attempted again. Given only about 6 weeks to design all facets of the program, as the board of directors at Scottish Rite Hospital wanted it operational yesterday, so to speak, I had my work cut out for me. In this time, I had to design the structuring of enrollments, establish the criteria of admittance into the program, establish a payment scheme, design the long term athletic development programs for all of the major sports within the area, make known the schedule for the times and days of class offerings, come up with marketing materials, and so on. Being that this program was attempted already once and ended up as a total failure, I had no blueprint to go off of either. So I was given the go ahead, so to speak, to act within my best discretion using the limited resources I had available to me, which honestly wasn't much. As between 8 therapists, each seeing 2 patients every hour, we had the following equipment for both the bridge program that I was designing and the entire sports physical therapy division at Scottish Rite Hospital to share. One pair of dumbbells ranging from 5 to 50 pounds, 4 kettlebells that were 48 kilograms each, one kettlebell of each of the following weights: 2, 4, 6, 8, 10, 12, 14, and 18 kilograms, 3 open trap bars, 2 closed trap bars, 3 Kaiser machines with standard attachments included, 1 slide board, 2 TRXs, 4 benches, 4 battle ropes, 11 sandbags ranging from 30 to 60 pounds, 2 prowlers, 1 Vertimax, and an assortment of med balls and stretch elastic bands. Outside, we had a 45-yard track as well. Reserved mainly for PT purposes, we also had 6 AirX pads, 2 gymnastic mats, a plyo box set ranging from 6 to 36 inches in height, 7 treatment tables, 5 BOSU balls, 5 TheraMols, 2 agility ladders, and really a standard hurdle set of small, medium, and large hurdles. So, with most of the equipment I just listed being used by the sports physical therapist in a small shared space, which got tight as I eventually grew the program to class sizes of 20 plus individuals, I had to get creative, as in addition to being the bridge program coordinator during this time, I was also its head strength and conditioning coach, being that I was just a program of myself. So I worked on the floor and coached daily a wide variety of sporting participants from all different backgrounds and sports, especially being that the restrictions for admittance into the program were minimal under my leadership. As, for instance, I eliminated any time restrictions for post op individuals. So, in the program's first month, I ended up seeing only 46 total visits for the month. Fast forward 8 months later, I was up to 450 visits per month, and I had the justification I needed for adding 2 more additional strength and conditioning coaches to my staff, who I also trained and developed as they had no experience in the field prior. The program itself also garnered a great track record for returning participants back to sport at or before 9 months, as 87% of athletes who were status post ACL reconstruction were able to pass their return to sport testing by this time point. And while I coach classes that were composed of a variety of diagnoses, who were also of differing lengths of duration from their date of initial surgery, these classes were also comprised of participants of various sports and ages as well. So these results I just listed really flew in the face of the odds my team and I were dealt. For instance, a smaller class that I coached and had other interested applicants coach who were interested in being my replacement as bridge coordinator during my out processing included the following. Participant 1 is a healthy 10-and-a-half-year-old male with no significant medical history, and he really only engaged in periodic recreational games at school with friends. Participant 2 was a 17-year-old female with idiopathic scoliosis and right bicep tendonitis with episodic flare ups for the last 7 months. She mainly just works out for fitness reasons, prior swimmer. Participant 3 was a 18-year-old male with bilateral hip impingement, FAI, and he was status post left hip scope 7 months ago. He was a baseball player attempting to return back for his senior year. Participant 4 was a 15-year-old male basketball player, status post right knee scope, with debridement and bone grafting and fixation of his medial femoral condyle for osteochondral defect 6 months ago, and he's trying to get back to playing basketball. Participant 5 is a 15-year-old male, status post right ACL reconstruction and meniscus, and I told interested individuals who were interviewing for my position that he can perform impact activities currently. This patient was also status post ORIF of his right scaphoid for a non-union fracture. He was a football and basketball player. Participant 6 was a 15-year-old healthy female with a history of tibial stress fractures roughly 7 months ago, and this individual was a track athlete. Participant 7 was an 18-year-old male football player, 6 months status post medial meniscal repair. Position was O-line. Participant 8 was a 16-and-a-half-year-old male football player, 7 months post ACLR in meniscal repair, and he played D-line. And then participant 9 was a 16-year-old male, status post ACL and MCL with meniscal repair 6 months ago as well, and he played soccer. So as some people can see, that was a very diverse class composed of a wide variety of sports and injuries. Other notable statistics from the program included that 100% of all athletes were able to return to sport at 11 months post op as well, and that we had a re injury rate within our ACL reconstruction population of 0% at the 2 year post inception mark of the program. As after that time, tracking of the program's data by me stopped as I ended up leaving Texas to become the clinic director of the Human Performance and Rehabilitation Center in Hawaii. So, overall, by all accounts and measures, the program was a success, as even the admins and orthopedic surgeons at Scottish Rite Hospital were talking to me only a year later about expansion opportunities of the bridge program into different satellite clinics or facilities around the state. And this was obviously because I accomplished a lot of the objectives the hospital had in mind in the first place when agreeing to fund and support the bridge program that I created, which namely consisted of me and my team offloading patients from the sporting division of physical therapy to the bridge program, thus allowing for increased access to medical care by the local community, the generation of multiple streams of revenue for the hospital through the offerings of performance training, the improvement in return to sport rates seen in the post-operative ACL population seen at Scottish Rite Hospital, and the intercollaboration of hospital staff, as the hospital itself became less siloed as I actively involved our movement science lab into my bridge program for data tracking and research purposes. Now, while I am proud of the above statistics and the experiences I've laid out thus far within this video, the only reason I mention them is because it laid the foundation for the program I wish to speak of in this video. In my time as both a clinician and coach, I've completed the plans of care from the early acute phases through the performance phases when viewed from a rehabilitation perspective of just over 300 separate patient athletes who were status post ACL reconstruction. Average discharge times for these 300 individuals by me was roughly 8 months, and I've only had one re-tear in my professional career as a sports physical therapist. Thus, the tracking and comparing of my outcomes to the cited norms of the literature showed me that I was achieving results and outcomes that were much improved when compared to that of my colleagues. This is because normative results cited in the literature for return to sport are currently at only 55% for patients who are status post ACL reconstruction. And this statistic also accompanies a 30% re-injury risk to the repaired or reconstructed ACL of the athlete within 2 years of the return to sport release as well. Upon this realization, I decided to create my own course detailing the methodologies I use for ACL rehabilitation, which were influenced from my time learning from the leading experts from within the industry during my stays in various high performance settings, as the perspectives I gathered are from the professional, private, military, and hospital settings that I've worked in. These perspectives are all very different and unique when compared to one another, but most importantly, tried and tested, as they were instrumental in several different programs that I've developed, including the bridge programs that I spoke of earlier. This masterclass I've created on ACL rehabilitation is also unique from other courses in that it is predominantly application-based, as enrollees will immediately learn easily digestible therapeutic exercise progressions that can be implemented starting on post-op day 1 of an athlete's rehab. Not only that, but these progressions also span the entire continuum of care for the athlete, as I take the viewer of this program through each and every phase of rehab, including the return to performance phases of rehab, so that by the end of the course, all enrollees can effectively coach and effectively prescribe training means and methods to best fit the athlete in front of them. The personal goal I had when creating this course was to give each and every enrollee of this course the knowledge I've gained through my professional career, both as a physical therapist and as a strength and conditioning coach. I wanted to organize and impart this knowledge to the viewer of this course so that they personally had the means I used and implemented when creating the bridge programs for ACL performance training that I was a part of, both in the private sector and at one of the world's most distinguished orthopedic hospital systems. And I tried to do this in a manner that used strategies that scaled the entire care continuum, from the table to the turf, and which could be immediately implemented by sports medicine professionals so that they could more readily overcome the major milestones commonly experienced by patients who are status post ACL repair or reconstruction. Not only did I try to detail these strategies, but I also provided them as downloadable materials in both print and video formats as well within this course. As I give the world's first long term athletic development program, which was tailor made for most of the major field sports. This blueprint for ACL rehabilitation comes with over 2,000 separate and individual videos that are logically programmed from a frequency, intensity, time, and type perspective in order to best return the patient athlete not only back to sport, but beyond pre injury levels. Additionally, the course comes with over 35 hours of voiceover videos by me, where I provide the complete context for why the patient is performing what was programmed, complete movement progressions or regressions to use when scaling interventions to the patient, and an assortment of verbal and visual cues to use for the athlete when cleaning up the commonly experienced movement faults for their different phases of rehab. Simply put, this is the most complete course from an applied perspective currently on the market for the topic of ACL rehab and reconditioning. Everything from strength training to load integration when performing fieldwork to teaching philosophies on safe and effective development of a patient's plyometric speed and agility mechanics to recovery enhancement methods and injury reduction strategies are discussed, and more importantly, demonstrated and walked through progressively in order to enhance the enrollee's clinical skills and expertise with regards to ACL rehab. Additionally, broadened opportunities for career advancement through the earning of 30 hours of continuing education credits are also offered with the purchase of this course, as well as the guarantee by me to you that the knowledge and skills the enrollee will learn upon purchase of this course and completion of it demonstrate the highest commitment in providing your athletes with the best possible care currently available for this pathology. With a full money back guarantee, I'm confident that the purchaser of this course will see value delivered back to them that exceeds their expectations and that results in opportunities that would have otherwise been unavailable to them. I can say this because the skills learned within this course will best allow the motivated learner to take actionable steps in either climbing the corporate ladder like I did, towards a more lucrative job position within sports medicine through the enhancement of their applied clinical knowledge, or better yet, students who complete this course will have opportunities to successfully open their own private sports training centers where both rehabilitative and performance services are offered. Much how like Andrew Doe, a former employee of mine, did just this past year. And while this course provides exercise selections in the form of trainable menus to ensure that more anchored decision making occurs through my giving of the viewer of this course an entire 68-week athletic development program tailor made for either bone patellar bone or quad tendon autograft choices for ACL reconstruction as well. This was also done to ensure that this course is the most comprehensive guide or blueprint on the market when navigating the vastness of physical preparation for ACL reconstruction when it comes to bridging the gap educationally between rehab and performance throughout the entirety of the rehab to performance continuum. Because of the scope of this course, the interested enrollee can either purchase it in its entirety or through separate modules as well. Regardless of what method the enrollee chooses to use when attending this course, they can still expect to be educated in applying the best available research and evidence while utilizing the systems, philosophies, and methods I've developed when building separate bridge programs both in the private sector and from one of the top ranked pediatric orthopedic hospitals in the United States, as both programs supported patients in their quest for return to performance who were status post ACL repair or reconstruction. Here in Module 1 of this Paradise ACL program, the fundamentals, the course enrollee can expect to learn the following: the ability to summarize current concepts surrounding ACL injury and outcome epidemiology, the capability to identify commonly experienced pitfalls that patients during the rehabilitation process for a status post ACL repair or reconstruction encounter, the capacity to identify potential opportunities for different members of the patient care team to interject their expertise while carrying out their professional responsibilities within their designated scopes of practice, the ability to develop a hypothetical model for the initial 8 weeks of the ACL rehabilitation process for a patient with regards to progressive exercise variability for normalization of their active and passive range of motion, proficiency in developing a hypothetical model for the initial 8 weeks of the ACL rehabilitation process for a patient with regards to progressive exercise variability for normalization of their ambulation mechanics on both even and uneven ground and when ascending or descending stairs, the competence to write a hypothetical model for the initial 8 weeks of the ACL rehabilitation process for a patient with regards to progressive exercise variability for maintenance of a patient's cardiorespiratory fitness and the repatterning of their running and sprinting mechanics, the aptitude to construct logical progressive and regressive movement sequences for variations of the major squatting, lunging, and hinging movement patterns during the initial 8 weeks of the ACL rehabilitation process for a patient, the capacity for programming open and closed kinetic chain interventions of different frequencies, intensities, and types while using graded movements comprised of varying tempos and muscle lengths for restoration of normal quadricep function to patients. The ability to verbalize the clinical reasoning and critical thinking skills in status post ACLR patients needed to justify and modify exercise interventions to facilitate the achievement of their needs and goals pertaining to their movement variability. In Module 2 of this Paradise ACL program, Bands to Barbells, the course enrollee can expect to accomplish the following: the ability to recognize, justify, implement, and coach different training means and methods into a patient's rehabilitation regimen, including supramaximal training methods, strength endurance interventions of varying tempos, explosive and maximal strength work, yielding versus overcoming isometric work, indirect sprint drills for both the patient's acceleration and max velocity phases of sprinting, varying deceleration locomotive strategies, and varying transition locomotor strategies for field work that requires the patient to change direction. The enrollee should also be able to design, implement, and coach athletes while using both a block and a triphasic periodization model for progressive field and weight room work of higher intensities for athletes who are status post ACL repair or reconstruction upon completion of this module. Enrollees should also be able to better regress and progress prescriptive exercise to the current levels of movement and locomotor capabilities of patients who are status post ACL repair or reconstruction, while developing their energy system capacities in efforts to address any areas of limitation that they may have. Enrollees should additionally complete this module with an enhanced understanding of the systems and processes necessary to build, implement, and coach a thorough reconditioning plan to help athletes that are status post ACL repair or reconstruction with return to sprinting and unrestricted weight room work through the organization of therapeutic progressions into logical phases of rehab. Enrollees should gain a better understanding from a programming and coaching standpoint of the processes and systems needed to meet the demands for return to play for athletes who are status post ACL repair or reconstruction as well. Enrollees should gain an appreciation of the team-based approach required for the proper rehabilitation of athletes who are status post ACL reconstruction. along with an understanding of the holistic approaches currently available to athletes in aiding their recovery from the physical stresses placed upon them during the rehabilitation and reconditioning process. Enrollees should gain an understanding of the progressive ways to coach and implement various neuromuscular interventions of higher intensities into a patient's rehabilitation plan or a status post ACL repair or reconstruction as well. In Module 3 of this periodized ACL program, late stage rehab, the course enrollee can expect to accomplish the following: the ability to design, implement, and scale a logical return to run program that is progressive both in terms of foot contacts and mileage ran for athletes for a status post ACLR, the ability to design and coach a sprint program that is progressive both in terms of frequency and intensity for athletes who are status post ACLR in order to improve their sprinting economy, efficiency, and speed during competitive sport, the ability to coach and design drills of higher intensity and means for the enhancement of the patient athlete's change of direction abilities during competitive sport, the ability to scale neuromuscular and neurocognitive interventions to return to sports skill levels for athletes who are status post ACLR while incorporating different sprinting and change of direction work that is specific to the athlete's needs, the ability to construct and coach various locomotor, plyometric, and agility interventions to facilitate a graded return to activity or sport in patients who are status post ACLR, an enhanced training and exercise menu for understanding the methods required to infuse both rehabilitation and physical preparation principles into a patient's training regimen who are status post ACLR so that the necessary adaptations for return to play and sport can be optimized. And in Module 4 of this periodized ACO program, Return to Performance, the course enrollee can expect to accomplish the following: to gain a greater understanding of the efforts required to transition an athlete from a physical preparation standpoint from return to sport to return to performance, while using graded exercise which is scaled to span the continuum from non contact to contact practice and game like scenarios, the ability to teach philosophies and frameworks for various exercise progressions to an athlete that is status post ACLR, including plyometric drills, reactive drills, and return to competition strategies for end stage ACLR rehabilitation and reconditioning, the ability to design and coach drills of higher intensities and means for the enhancement of patients' change of direction and agility mechanics during competitive sport. The enrollee should also be able to design, implement, and coach athletes while using elements of a block, conjugate, and undulating periodization model for progressive field and weight room work of higher intensities for athletes who are status post ACLR upon completion of this module. Enrollees should also be able to design, implement, and coach athletes who are in season for their sport while using elements of microdosing in order to gain an appreciation of and respect for the other ancillary professions within sports medicine, such as strength and conditioning. Enrollees should gain the ability to write a comprehensive training regimen encapsulating all elements of rehabilitative needs for athletes who are status post ACLR in order to discharge them back to sport or performance. Enrollees should gain a respect for rehabilitation considerations across a continuum of care with accompanying training techniques for the physical preparation of patients status post ACLR for return to sport and performance as well. Enrollees should gain exposure to existing and emerging technologies that can be integrated into ACLR rehabilitation and ultimately the patient's training and or performance regimens once the patient is cleared for return to sport. Enrollees should gain exposure to existing and emerging technologies that can be integrated into ACLR rehabilitation and ultimately the patient's training and or performance regimens once the patient is cleared for return to sport. So, as a whole, this periodized ACO program and its accompanying modules were designed to enhance providers' confidence, clinical reasoning, and coaching skills with regards to developing care to patients who are status post ACLR. This is because, as clinicians and coaches, we know that periodization programs for ACL pathologies within the rehabilitative and performance fields are desperately needed, but that standardization and implementation are everywhere and really only hypothetical at this point. That is why, through this course, I aimed to teach, educate, and improve upon what the current outcomes are for this pathology while demonstrating in video format progressively graded exercise that is periodized to best meet the demands of most field athletes who are status post ACL repair or reconstruction for return to sport. This course was really designed with the intention of providing students with the clinical experience commonly encountered only by students within the fields of athletic training, physical therapy, and strength and conditioning who were lucky enough to serve in the high performance model of sport. Typically, this requires students within these disciplines to work for free during their clinical rotations for months on end in order to learn how to apply the knowledge they gathered during their didactic coursework while in college or university. Even worse, this occasionally requires postgraduate clinicians who are interested in making the switch to sports medicine to volunteer what little and precious time they have outside of their full time job to field coverage and internships so that they can gather the necessary experience to make the jump to a more fulfilling career. This course aims to fill that clinical void from an application standpoint as it serves as an instrument for mentorship so few of us sports medicine professionals had during their graduate work. While using ACL reconstruction as the vehicle for learning sports medicine concepts and principles, this course guarantees to provide the most comprehensive framework currently available for the rehabilitation, reconditioning, and physical preparation needs of patients who are status post ACLR with regards to optimizing their outcomes across the continuum of care. With over 2,000 videos and 35 plus hours of content, all enrollees will possess an enhanced knowledge and confidence to being able to competently work with an ACL patient from the start of their rehabilitation journey while on the table through their discharge back to the court or field of play for their respective sport. And in order to educate providers within the sports medicine team on how to bridge the gap from the clinic to the field while best utilizing and applying current research for ACLR rehabilitation, a complete blueprint to this process is provided in the form of an Excel spreadsheet that has accompanying videos with voiceovers to ensure the interested learner will be guided completely in returning the athlete back to sport at or beyond pre-injury levels as well. Everything from program design to exercise prescription and modifications, along with recovery tips and tricks for the acute, mid, terminal, return to play, return to sport, and return to performance stages of rehab will be covered in order to enhance the enrollee's confidence and clinical competence with performing this rehab for patients who are status post ACLR. Progressions for attainment of all major milestones for this rehab will also be detailed starting on post-op week 1 and will continue through discharge back to sport and performance as well, due to the fact that I firmly believe successful outcomes for this surgery lie in applying learned concepts through a teachable and coachable format for athletes who are status post ACLR versus the typical classroom learning environment of information and theories that doesn't provide the practical skills needed for success in this rehabilitation. So, if you're looking for the fastest way to build your clinical skills, to provide better patient care, and to navigate the return to sport process with improved confidence in your ability to consistently deliver superior outcomes to your patients, come experience the competitive advantage today in returning your patients back to peak performance.